Hi friends, today I will talk about rabies. First is the disclaimer. This video is made for medical professionals for educational purpose only and there is no endorsement for any brand or company. As we know, this rabies is a zoonotic viral disease. It is caused by the bite of a rabid animal, and the virus responsible for this is rabies virus. It is a single stranded RNA virus. It is rod shaped or bullet shaped. It belongs to the family of Rhabdoviridae and the genus is Lysa. It is mostly transmitted through the saliva of the infected animal. Dogs are mostly responsible for rabies. They account for 95% cases. Occasionally, the transmission is also seen with the cats, that is 2%, bite of the monkeys, cattle, buffaloes, mongoose, wolves, fox, jackals, sheep, and goat. Even the bear, pigs, donkeys, horses, camels, spotted deer, and squirrels bite have also been reported to cause rabies. Rarely, few cases of bite by bats, rodents, and birds is also seen. All the exposure in the wild are considered as a category 3 exposures. Bite by the bats or rodents do not ordinarily necessitate rabies vaccination in India. However, the bites by the bats or rodents in the unusual circumstances may be considered for vaccination in consultation with experts in the field of rabies, especially the people living near the or in the forest areas. Till date, one case of squirrel bite leading to rabies has also been reported in India. The modes of transmission, it is by the bite from the infected animal, licks on the broken skin or the mucous membrane, and even the scratches. Rarely, the rabies is transmitted by inhalation, organ transplant like cornea, or through the ingestion. The incubation period for rabies is 30 to 90 days but may vary from 2 weeks to more than a year. It is shorter if the bite is close to the brain and a massive dose of the virus has been inoculated. The factors which influence the incubation period, they are site of the bite, amount of the virus in the saliva of the biting animal, strain of the virus, and age and immune status of the victim. Whenever the animal bites, the viral inoculation from the rabid dog bite or rabid animal, that virus replicates in the muscles, and from the muscle it binds to the nicotinic acetylcholine receptors at the neuromuscular junction. Then the virus travels to the within the axons in the peripheral nerves through the axonal transport to the spinal cord where the replication takes place in the motor neurons of the spinal cord and the ganglia, and then it travels to the brain where it causes the encephalitis. Encephalitis is the inflammation of the brain parenchyma, and then it enters the salivary glands and other organs of the victim. Rabies presents in three phases. First is the prodromal phase, then excitation phase, then excitation phase and paralytic phase. The prodromal phase presents as a discomfort or pain at the site of the bite, numbness and tingling in the limb, increased temperature, patient may have malaise and headache, sore throat, priapism. Excitation phase Patient has restlessness, tremor, pharyngeal or laryngeal spasm. Patient has a fear of water, which is called hydrophobia. He feels thirsty and he is dehydrated. Patient has difficulty in deglutition. Patient has respiratory distress. He has change in the voice tone. Patient can have cardiac arrhythmias. He his blood pressure increases. He has autonomic instability. He has fear, agitation, and and on further exposure to light, air, or sound, he feels agitated and has a fear. Patient can have convulsions and death. I have a small video from a Lancet. I have taken it from a YouTube. How the patient have a fear of light, air, and sound and water.
The patient exhibits remarkable periods of agitation, alternating with calm, a key feature of the furious type of rabies. Note, the patient has difficulty with secretions. Notice the patient experiences gagging and pharyngeal spasms with this noxious stimulus, hypersalivation or foaming at the mouth. He experiences great difficulty swallowing his excessive saliva with notable gagging. The rabies virus is found in high quantities in saliva at this stage.
So we saw in that patient has a severe laryngeal and pharyngeal spasm. His own secretions, they were causing spasm in the pharynx or the larynx. She was restless, and the next phase is the paralytic phase. The patient goes into unconscious state or altered sensorium. He develops flaccid or limp muscle paralysis, and he throws repeated convulsions, and ultimately patient dies. The, as of now, there is no treatment available for once the rabies occurs in a patient. Only the prevention is the best strategy. In prevention, we have wound care management, and we have post exposure prophylaxis and pre exposure prophylaxis. The animal wide wounds, they are categorized in three categories, and depending upon these categories, we give the anti-rabies vaccine or immunoglobulin or monoclonal antibodies. In the the category 1 type of wounds are just touching or the feeding of the animals, licks on the intact skin. Sorry. Sorry. In category 1 wound, we have touching or the feeding by the animals, or when we feed milk of the rabid animal, or licks on the rabid animal, licks on the intact skin, or the contact of the intact skin with the secretions or the excretion of the rabid animal. These all categories, these all types of contacts are categorized as category 1 wound, and in these cases we don't give any rabies vaccine, provided we must have a reliable history. We just have to wash the exposed area with water and soap and apply the antiseptic. No anti-rabies vaccination is required for category 1 wound. In category 2 or category 2, there is nipping of the uncovered skin, or patient can have minor scratches or abrasions without bleeding. So all the scratches, abrasions or wounds nipping without bleeding are categorized as category 2 wound. Here we have to give rabies vaccine besides managing the wound. In category 3, patient have single or multiple transdermal bites or scratches. He has licks on the broken skin, or there is contamination of the mucous membrane with the saliva. This is the category 3 wound. Here we have to give rabies vaccine, and besides rabies vaccine we have to give rabies immunoglobulins and monoclonal antibodies. Remember, bite by the wild animals and all bites in the forest area should be considered as a category 3 exposure, and they should be given rabies immunoglobulin and rabies vaccination. So these are all category 3 wound, where we can see that there are transdermal bites and there is oozing of the blood in all these three. So all these three wounds, they are category 3 and they have to be subjected to rabies immunoglobulin, and patient has to be given rabies vaccine. So coming to the management of the bite wounds, whenever such patients reports to us, the rabies virus usually enters the body, scratches or the bite site by the saliva of the animal. Our target should be remove as much as saliva as possible with no additional trauma. So whenever the patient reports to us, we should immediately flush and wash all the wounds with soap and water for at least 15 minutes, and then we can apply povidone iodine or any antiseptic alcohol preparation. As we know that rabies virus, they persist and multiply at the site of the bite for a long time, the wound management must, even if patient reports late. So even if the patient reports late, we must wash his wound. Even if we don't have any soap or virucidal agent, then we can just wash the wound with running water. And if the patient has his eyes and mucosa contaminated with the excretions of the rabid animal, we must rinse it thoroughly with water. Coming to the post-exposure prophylaxis, this post-exposure prophylaxis should be started immediately after exposure. Observation period for 10 days is valid for dogs and cats only. So especially if they are pet animals, pet dogs and pet cats. Here, if the dogs or cats they survive after 10 days of observation period, then we can modify the post-exposure prophylaxis by converting it into the pre-exposure prophylaxis by skipping just one dose of which we give in post-exposure prophylaxis on day 14. Instead of giving it on 14, we will give it on day 28. I will come to the post-exposure prophylaxis. Usually we give 5 doses on 0 day, 3 day, 3rd day, 7th, 14 and 28 days. We give 5 intramuscular injections. So if the dogs or cat survives for 10 days, we can skip one dose on day 14 and instead we can give it on day 28. So if the dog or cat survives after observation of period of 10 days, we will just give only 4 injections instead of 5. But this method or this treatment modification is valid only for intramuscular rabies vaccine injection. We don't have to apply this formula for intradermal route of administration. If we are giving intradermal route of administration, we will give the complete course of vaccination irrespective of the status of the biting animal. So coming to the vaccination status of the biting animal, even just remember that even if the biting animal is vaccinated, you consider it as it is non-vaccinated, it is not vaccinated, and we should give post-exposure prophylaxis irrespective of the vaccination status of the biting animal, because we know that vaccine failure may occur because of improper administration, inadequate doses, poor quality of the vaccine, or the poor health status of the animal. So, irrespective of the vaccination status of the biting animal, the post-exposure prophylaxis must be given. Is there any contraindication to the use of rabies vaccine? No. As we know that rabies is 100% fatal disease, there is no contraindication to post-exposure prophylaxis for rabies vaccination, especially the patients who are pregnant, lactating women, old age, any concurrent illness. There is no contraindication for the use of rabies vaccination. However, people who are on chloroquine treatment for malaria or hydroxychloroquine, they may have a reduced response to intradermal rabies vaccination. So in such cases, we can give them intramuscular vaccine. All cases of patients who are given vaccination, they should be observed for 15 to 20 minutes after vaccination to look for any adverse drug reaction. As we know that rabies has a long and variable incubation period, even if the people who present late to you, they should be considered as a fresh cases, and they should be given rabies vaccination as if they have just been bitten by the rabid animal. In post-exposure prophylaxis, first of all, our main motto is management of the bite wound. Then we have two types of immunization: passive immunization and active immunization. Passive immunization means we give immunoglobulins or monoclonal antibodies which neutralizes the rabies virus at the biting site. And active immunization is the rabies vaccination which we give, and after a period of 7 to 8 days of first injection, the rabies antibodies, they start developing in the patient and they start neutralizing the virus. So passive immunization is we inject antibodies into the wound and they neutralize the rabies virus. And active immunization which develops after 7 days of vaccination. These are the few examples. I am not endorsing any brand. These are we have rabies immunoglobulins and rabies monoclonal antibodies. The rabies immunoglobulin, they come as human rabies immunoglobulin and the equinus human rabies immunoglobulins, and we have rabies monoclonal antibodies. They provide passive immunization. They are to be injected at the bite site and they will neutralize the virus at the bite site. And in anti-rabies vaccine we have Rabipur, and the schedule of how to give these rabies immunoglobulin or monoclonal antibodies and vaccination I am going to discuss in the next slides. So whenever we are treating any patients of rabies, make sure that you don't touch the wounds with the bare hands. Don't apply any irritant like soil, chili oil, lime, herbs, chalk, betel leaves. So whenever we have patient with category 3 wounds, we know that in all category 3 wounds we have to give monoclonal antibodies or rabies immunoglobulin. They have to be infiltrated into the wound or around the wound just to neutralize the virus present in at that site. And the severe bite wound which requires the suturing Suturing can be delayed for few hours, and in those cases first inject the rabies immunoglobulin or the monoclonal antibodies, and once you are sure that you have properly injected the rabies immunoglobulin or monoclonal antibodies, and you have given rabies vaccination also to the patient, then after a few hours, like 15-20 hours, we can suture the bad severe wounds also. But make sure that you always wear gloves while dressing or suturing. So this is another video which I have taken from this is prepared by our respected Dr. Anurag Agarwal sir, and just goes through the video how this rabies immunoglobulin or the monoclonal antibodies, they are infiltrated into the wound. Just this. You can see that how the rabies immunoglobulin, they are injected. This is as we give local anesthetic agent while suturing. Similarly, we have to give this rabies immunoglobulin. Sorry. So, if any wound which required suturing, make sure that you have given him rabies vaccination and rabies immunoglobulin, and we can wait for the suturing for 15 to 20 hours. Bites on the tips of the fingers or toes, ear lobules, nasal area or genitalia, then they should also be given rabies immunoglobulin, but avoid excessive pressure to avoid the compression syndrome. Tetanus toxoid is to be given to all such cases as per the guidelines, and to prevent the sepsis, give suitable antibiotics. Coming to the rabies immunoglobulin, as we know that rabies immunoglobulin, they provide the passive immunity in the form of ready-made antibodies before it is physiological possible for the victim to produce his or her own antibodies following the anti-rabies vaccination. These rabies immunoglobulins, they neutralizes the virus, and the virus loses its infectivity. This should be given in all category 3 wounds or in all wild animals bites, and they should be given in category 2 wounds in the patients who are immunocompromised, especially the patients who are HIV AIDS, patients on steroids, cancer chemotherapy, and the patients who are on who have congenital A gamma globulinemia. Rabies immunoglobulins, they are equine rabies immunoglobulins, human rabies immunoglobulin. The dose for rabies immunoglobulin equine is 40 international units per kg body weight. Human rabies immunoglobulin is 20 international units per kg body weight. Maximum we can give 1500 units to a patient. Before injecting, we should bring it to the temperature of 25 to 30 degrees Celsius. They should be administered whenever the patient with category 3 or category 2 as advised, and immunocompromised patients, and she should be started immediately after the initiation of the post-exposure vaccination. If the patient reports after the 7th day of the first dose of vaccination, then there is no need to give rabies immunoglobulins, because such patients who have received rabies vaccination prior 7 days before, they have started developing the antibodies, so we should not cause the wastage of the immunoglobulins. They are very costly. Don't give them in a patient who have already received complete course of pre-exposure prophylaxis or post-exposure prophylaxis, or who have already received rabies immunoglobulin in the past. We should infiltrate entire immunoglobulin into or as close possible to the wounds. Additional small wound or a child does not report all wounds, then we can give them intramuscularly also. The patients who have mucosal exposure with no wounds, the rinsing with rabies immunoglobulin can be considered. Exposure to rabies vaccine aerosol, especially in the ventilated patient, we can give rabies immunoglobulin uh, to healthcare worker by IM route also. Sorry, if there is exposure to rabies virus aerosols, we can give rabies immunoglobulin by intramuscular route. Don't give rabies immunoglobulin in the same syringe or at the same site where the rabies vaccine has already been given. Keep the patient under observation for 15 to 20 minutes after immunization. Rabies immunoglobulin must not be given intravenously. So, just to see the how these rabies immunoglobulin are available in the market. The market price for 300 international unit for rabies human rabies immunoglobulin is approximately 5200 to 5500, and the dose required for us is 20 international unit per kg, and average 60 kg individual will require 1500 international unit, means the patient will require at least 4 vials, and the cost of the 4 vials is approximately 22,000, just a single dose. And now I will compare it with the uh, rabies monoclonal antibodies. The rabies monoclonal antibodies are also given in the category 3 wounds. They are also similarly infiltrated into the wound, and the rest is given by intramuscular route. They are available in the strength of 1.5 ml, 2.5 ml, 2.5 ml. Each ml contains 40 international unit. Dose is 3.33 international unit per kg body weight. And if the patient has a multiple wounds, the dose may be diluted in solution of 0.9% sodium chloride in order to provide the full amount for good infiltration of all the wounds. Storage is 2 to 8 degree. So if we see the market price of monoclonal antibodies, it is 2200 or 2200 for 100 units, and average individual requires 60 into 3.3, means about approximately 200 unit, that is 2 vials, and the cost is 4400. And in case of immunoglobulin, it was about 22,000. So we can see the large amount of difference. It is very cheaper, 4-5 times cheaper than rabies immunoglobulin. They are very cost effective. So if the cost is an issue, we can give rabies monoclonal antibodies to the patient. Coming to the rabies vaccine, all the animal bite wounds of category 2 and 3, irrespective of the age, body weight, require the same number of injection and dose per injection. Dosage I will discuss. That storage is 2 to 8 degree temperature. The vaccine should be used immediately, not less than 6 hours. Side effects are headache, malaise, nausea, fever, mild pain at the injection site. If the patient is given rabies vaccine, preferably he should receive all injection of the same brand in the subsequent doses, but we should discourage switch over from one brand to another. National Rabies Control Program strongly advocates the use of intradermal routes of rabies vaccination, because intradermal route requires very lesser amount of vaccination for pre and post exposure prophylaxis, and so it reduces the cost of the vaccination. But we should avoid intradermal route of administration in patients who are immunocompromised or patients who are on chloroquine or hydroxychloroquine, or patient on long-term steroid or chemotherapy. This is how the intradermal injection is given. Like we give this BCG vaccination in children's. We have a updated Thai Red Cross regime for intradermal vaccination. 2 doses in each visits are given. So we give 0.1 ml of the vaccine per intradermal site, 2 sites per visit, one on each deltoid area. So the regime is on day 0, day 3, day 7 and day 28. We give 2 injections per visits. So patient has to come 4 times. Patient has to pay 4 visits. In every visit we give 0.1 ml in each syringe at 2 sites on the deltoid, two deltoid right and left. So in every visit the patient will have 2 injections. Then intramuscular regime is 5 doses. Here we give only 1 injection per visit. The dosage is schedule is on day 0, 3, 7, 14 and 28 days. The vaccine is administered intramuscularly in the deltoid region, and in children we can give on anterolateral aspect of the thigh. We should never give this vaccination in the gluteal region because of decreased absorption. So the IM or intradermal injections of the rabies vaccination are given in category 2 and category 3 exposure wounds. How do we manage patients who has already previously vaccinated? So in previously vaccinated individual, we have to properly manage the wound. There is no requirement of rabies immunoglobulin or monoclonal antibodies. If patient has documented proof of complete post-exposure prophylaxis and pre-exposure prophylaxis in last 3 months, then there is no requirement of any vaccination. We will just wash the wound adequately. However, the people who have previously received full post-exposure treatment with neural tissue vaccine or vaccine of unproven potency, or who cannot document complete previous exposure or post-exposure treatment, they should be treated as a fresh case and they should be given full post-exposure prophylaxis. So in all cases, if the patient gives us documented evidence of post-exposure prophylaxis and pre-exposure prophylaxis within the last 3 months, there is no requirement of any vaccination. And if he gives documented evidence of post-exposure prophylaxis and pre-exposure prophylaxis in the last 3 months, then we will give him 1 injection on day 0 and day 3, and if the patient has a documented evidence of pre-exposure or post-exposure in the last 3 months, we will just give him adequate wound wash, no requirement of any rabies immunoglobulin or no requirement of any vaccination. If it is more than 3 months and patient gives documented evidence of post-exposure prophylaxis or pre-exposure prophylaxis, we will give him intradermal or intramuscular injection of rabies vaccination on day 0 and day 3, and there is no need for rabies immunoglobulin. But the patients who don't have any documented evidence or who have received neural tissue vaccine or vaccine of unproven potency, or they don't have any complete previous treatment record, we should consider them as a fresh case and they should be given full post-exposure prophylaxis. These are the few sites where we should give rabies vaccine, intramuscular, intradermal, and these are the sites, and we should avoid in the gluteal regions. In children we can give in anterolateral aspect of the thigh also. Coming to the pre-exposure prophylaxis, Pre-exposure prophylaxis is given in the lab staff people who handle the virus and the infected material, clinician and the individual who attend the human rabies cases, animal handlers, dog catchers, wildlife wardens, quarantine officers who travel from the rabies free area to rabies endemic area. Indian Academy of Pediatrics recommends pre-exposure prophylaxis for the children on voluntary basis. Here we give on of 3 doses of rabies vaccination on day 0, day 7 and booster on day 21 or 28. Similarly, intradermal vaccine is given as 0.1 ml at one site only. In post-exposure prophylaxis, intradermal was given on two sites, both deltoids. But here, in pre-exposure prophylaxis, the intradermal vaccination is given only one injection on day 0, day 7, and booster on 21 or 28 days. And these are all high-risk group. They should check their neutralizing antibody titer. If the titer is less than 0.5 international unit per ml, then the booster dose is required. The sero monitoring is required every 2 years, and if the neutralizing antibody titer is less than 0.5 international unit per ml, then they are also given the booster dose. This is the summary of the vaccination schedule. You can take out its this is the treatment record of the patient. Whenever the patient reports to us, this is taken from the National Rabies Control Program, and we have to categorize the wounds. We have to mention on what date the patient is given the rabies vaccination, what is the next date. This is the protocol for rabies post-exposure prophylaxis after animal bite. We have to vaccinate the animal to stop the transmission, and we have to vaccinate the victim to save their lives. This is a small video which shook all of us, that just because of lack of vaccination, lack of awareness on the part of general public, that a child named Babu lost his life in Andhra. Just go through this video. I have taken it from YouTube.
ये खौफनाक सच्चाई है आंध्र प्रदेश के खम्मम की, जहां अस्पताल की चौखट पर एक बच्चा तड़प तड़प कर दम तोड़ रहा है, लेकिन उसकी मां, उसकी बहन और ये भीड़ आसपास खड़े होकर तमाशा देख रही है। तमाशबीन में वो डॉक्टर्स भी हैं जो इस बच्चे की जान बचा सकते हैं। सब लोग बेबस लाचार होकर इस बच्चे की मौत का तमाशा देख रहे हैं। 16 साल के इस बच्चे का नाम कहेला बाबू है। बाबू को कोई भी बीमारी नहीं थी। इसे 1 मई को गली के कुत्ते ने काट लिया था। ये खबर और तस्वीर आपको
So this child Shaila Babu in Andhra died because of bite by a rabid dog. Had he been given rabies vaccination or immunoglobulin, his life could have been saved. Being a doctors, it is our duty that whenever any patients who comes to us with the bite of any animal, we should give him at least the vaccination. The rabies vaccination is available in almost all the secondary or tertiary care hospitals, and we should make them aware that irrespective of the status of the biting animal, there we have to give the rabies vaccination. And we should make the public aware that biting by the dogs or cats or any other wild animal, they must receive the vaccine so that we can prevent this 100% fatal disease. Because if the patient suffers the rabies, then he will ultimately die. We can prevent the death. This is 100% preventable viral disease. We should not let another babu to die. This was my small effort to make you aware about the rabies. If there is any suggestion or any comment, please do write me in the chat box. Thank you.